Yes, doctor can start.
Okay. So today we'll be continuing with the part 2 of infectious disease. Uh, so we'll be seeing tetanus first. So tetanus, also known as lockjaw, is a bacterial infection caused by Clostridium tetani and is characterized by muscle spasm. Here, commonly lockjaw is colloquially called, tetanus and lockjaw. The term is used interchangeably, but we know tetanus is not lockjaw is not the only symptom of tetanus. So, Clostridium tetani is a common soil bacterium, and that's a causative agent of tetanus. Vegetative cells of Clostridium tetani are usually rod-shaped. As seen in the photo picture, it is rod-shaped, and the spores are extremely hardy. So, Clostridium tetani has this capability of producing spores, and these spores are extremely hardy and can be found globally in soil or in the interstitial tract of animals. And if inoculated into a wound, this can grow and produce potent toxin, especially tetanospasmin. So, most of the symptoms produced in tetanus is due to the toxin tetanospasmin produced by the organism, and this interferes with motor neuron causing tetanus. So Clostridium tetani causes tetanus, and the most common presentation is muscle spasm. It's a organism capable of producing spores. So predisposing factors, if we look, we can see that absence of prior tetanus toxoid immunization is one of the most important reasons why people get tetanus. And trauma with laceration, deep wound, crushed, devitalized wound, presence of foreign body, wounds with anaerobic environment in the tissue. We know all these things here. Any wound that can lead to anaerobic environment for the growth of this organism uh, can become tetanus. So if the spores are entering into any tissues in the body, and if there is an anaerobic environment which promotes the growth of this bacteria, tetanus can be resulted in. So tattooing, rusted nails, earlobe prick, colloquial perianal therapies. These are the common ways in which people usually get affected with tetanus. But there's a myth that only rusted instruments will cause tetanus, which is not true. Yeah. Chronic suppurative otitis media, that is one more way in which people can get or like tetanus. Like if CSOM is there, it can harbor a situation which can lead to tetanus. Another one is caries in the teeth. These are not common reasons, but even CSOM and caries of teeth can lead to tetanus. It's not communicable from person to person. Here, if you look, we can see that first the spore will enter into the wound, and it germinates in anaerobic media, releasing bacteria. So spores will germinate, and bacteria will be released, and these bacteria will multiply. And once it is multiplied, it will start releasing exotoxin here. So it's an exotoxin. Remember, it's an exotoxin, and the main exotoxins produced here are tetanospasmin and tetanolysin. I told earlier, tetanospasmin is what causes all the symptoms that we see. Then there is tetanolysin, which is capable of hemolysis. And if you look at what's happening with tetanospasmin, we can see. So before that, this is a motor neuron. So this is a muscle fiber, and here there is a neuron, and this is a motor neuron. Here we can see the cell body with dendrites. We can see the axon here. Then we can see the axon terminals. Here the muscle fiber is there, and then there is neuromuscular junction. Okay, and imagine these are inhibitory neurons and excitatory neurons. So you know, excitatory neurons, they have a capability to, or they continuously sends excitatory signals, and the excitatory signals from excitatory neuron reaches the axon reaches the motor neuron, and finally it excites the muscles, right? And usually these excitatory neurons send a lot of signals. I mean, more than what is produced, they'll send a lot of signals, and these extra signals are cancelled out by inhibitory neurons. We know inhibitory neurons send inhibitory neurotransmitters. The most common ones are GABA and glycine. GABA and glycines will be sent out by inhibitory neurons. And these inhibitory neurons like GABA and glycine are usually responsible for cancelling the excess excitatory neurons. So they act in balance so that there is no hyper excitations or anything. So excitatory neurons are there. They continuously send signals to this motor neuron, but these extra signals are cancelled out by inhibitory neurons, inhibitory neurotransmitters like GABA and glycine. Here, what happens in case of tetanus is, so if we look close, we can see, let's imagine this is the spore. This is a spore, Clostridium tetani spore, and the spores will release bacteria and eventually toxins are there. Let's imagine that this is technospasmin. So technospasmins will be released to the neuromuscular junctions, and from there it will be taken up by this axon. Through the axon terminus, it will be taken up. It will reach the axons and it will go up, and finally it will reach the cell body. So we can see there is signals usually come in this direction, right? From the cell body to this axon to this muscle. Here we can see this toxin is going upward. So it's a retrograde direction. In the retrograde direction, these toxins are going. So after reaching the cell body through the dendrites, it goes into the presynaptic area. So here the direction is opposite of usually how these signals are passing. From, let's imagine this is the inhibitory neuron. An inhibitory neuron, we know from here GABA and glycine will be released. These toxins will cancel out GABA and glycine. So tetanospasmin usually inhibit the production of GABA and glycine. So what happens here is that excess signals won't be cancelled out by GABA and glycine. Tetanus toxin specifically blocks the release of neurotransmitters GABA and glycine from inhibitory neuron. So this is one important question. Tetanus toxins are cancels out GABA and glycine here, and these neurotransmitters keep overactive motor neuron from firing, and also play a role in relaxation of the muscles after contraction. So the normal function of GABA and glycine was to cancel out the extra signals from the excitatory neurons, as well as they help in relaxation of the muscle after contraction. So the first one is so here, when inhibitory neurons are unable to release their neurotransmitters, motor neurons fire out of control. The muscle have difficulty in relaxing. So two things happen when these GABA and glycine are not present. First thing is that these excitatory neurons will continuously uh, be present, and what happens is that there will be continuous excitation of the uh, muscle. And one more thing, after excitation, usually GABA and glycine used to help in relaxation. Here, due to the absence of these, relaxation will also not happen. So persistent excitation of the muscle is the result of this, that lead to all the muscle spasms and spastic paralysis towards the end. So how muscle spasm happen in tetanus, I think it's clear. It's due to the block in the release of GABA and glycine by inhibitory neuron, by this tetanospasmin. Here, tetanus neurotoxin selectively binds to and is transported to inhibitory neurons via endocytosis. So, that I'll discuss. So this toxin binds with GABA and glycine, which prevents excess excitation. So here endocytosis, so as I told earlier, it's a reverse retrograde transmission. So here, how is this toxin moving upwards? That's by endocytosis. So what's endocytosis? I hope you remember from physiology. So endocytosis is a form of active transport. So what happens here is that the material that is to be transported, that material gets internalized and gets surrounded by a cell membrane, and this forms kind of a vesicle, and that's how it moves upwards. And one example for endocytosis is phagocytosis. It's a form of active transport. So by endocytosis, this toxin gets transported upwards. So two things which are important in an exam point of view: one is endocytosis, and second one is retrograde transmission. These two are very important points. And second, and next, the cranial nerves usually involved here are, if trigeminal nerve is involved, it will lead to trismus or lockjaw. If facial nerve is involved, we'll get rhizus sardonicus. And if vestibulocochlear nerve is affected, there is hyperacusis. Hyperacusis is when the patient is excessively sensitive to noise. Then dysphagia will be resulted if vagus and hypoglossal nerves are affected. So these are the common symptoms. Trismus, we know it is defined as a painful restriction in opening the mouth due to muscle spasm. But as I told earlier, usually this trismus and tetanus are used interchangeably. The words are used interchangeably, but it's wrong because trismus is not the. Tetanus. The only symptom is not trismus, and trismus can happen due to various reasons. So other causes of trismus are usually broadly they are categorized into intra-articular causes and extra-articular causes. So trismus can result from tetanus, but the other causes for trismus are there are intra-articular causes and extra-articular causes. So some important intra-articular reasons are TMJ dislocation or any diseases related to temporomandibular joint, then like meniscus displacement, then fractured mandibular condyle or intracapsular fracture, then TMJ dislocation, then traumatic synovitis, septic arthritis, OA. So all these intra-articular reasons can contribute to trismus. Then there are a few extra-articular reasons like any like diseases related to teeth, especially if wisdom teeth is involved. We know there is a possibility of inflammation and edema, and that will in turn lead to trismus. Yeah. Two important reasons for trismus apart from tetanus are one is any disease related to TMJ, and the next one is any disease related to teeth, especially wisdom teeth. Here we can see how the patient is finding it difficult to open the mouth. And the next important symptom in tetanus is rhizus sardonicus. So rhizus sardonicus, or it's also called as rictus grin, it's a highly characteristic abnormal sustained spasm of the facial muscle that appears to produce grinning expression. The causes are, it may be other causes. One cause we know it is tetanus. The other causes which lead to rhizus sardonicus is one is strychnine poisoning. Next one is Wilson disease, and one more causes judicial hanging. We have learned in forensic medicine that judicial hanging can result in rhizus sardonicus. So tetanus, strychnine poisoning, Wilson's disease, and judicial hanging are the four important causes that lead to rhizus sardonicus. This is one picture of rhizus sardonicus. I think you can appreciate the characteristic grinning expression. So trismus is the most common symptom due to it's happening due to the spasm of masseter and pterygoids. Then rhizus sardonicus of smiling facies. It's a rigid smile due to spasm of facial muscle, especially zygomaticus major. Then jaw stiffness and stiffness in the neck and back muscles can also seen in tetanus. Then patient will be anxious, they'll be sweaty. There will be tonic clonic convulsion, headache, delirium, and sleeplessness can also be seen. There will be dysphagia and dyspnea. These are the main symptoms of tetanus. So in case of tetanus, the most important things to remember are retrograde transmission as well as endocytosis. Then next thing is gas gangrene. So here is a picture of gas gangrene. Gas gangrene is a bacterial infection that produces tissue gas and gangrene. So in this picture, I hope you can appreciate this gas production. This deadly form of gangrene usually is caused by Clostridium perfringens bacteria or Clostridium welshi. Earlier, this was called as malignant edema. It's also known as Clostridial myonecrosis or simply myonecrosis. So here, the most important organism that causes gas gangrene is called Clostridium welshi, which is also known as Clostridium perfringens. So this image, which is shown over here, is of Clostridium welshi. It's a gram-positive, anaerobic, central spore-bearing, non-motile, capsulated organism. But in addition to Clostridium welshi, other Clostridium family members can also produce gas gangrene, and these are Clostridium edemathium, Clostridium septicum, and Clostridium histolyticum. These are some other species of Clostridium that can produce gas gangrene. But in addition to Clostridia family, before that, Clostridium welshi, which is the most common organism behind gas gangrene, produce these toxins: alpha, beta, epsilon, iota. Here, three important factors are phytoxin that causes that's a myocardial depressant. There's kappa toxin, which lead to destruction of connective tissue and blood vessel, and then there is bursting factor. So apart from clostridial organism, there is one non-clostridial gas-producing organism, and that is coliforms. Coliforms can also produce gas gangrene. So coliform bacteria are defined as either motile or non-motile, gram-negative non-sporing non-sporophore bacilli. So we know Clostridia was gram-negative and it was central spore-bearing, whereas this is non-sporing and gram-negative bacilli. Coliform can also produce gas gangrene. Then how does a patient get this Clostridial sepsis? The most common one is contaminated, manure or cultivated soil and intestine. Fecal flora commonly contain Clostridial organism. Predisposing factors are commonly caused by crushing wound, road traffic accident, and amputation. Injury, ischemia, or necrosis of the muscle happens due to trauma. Anaerobic environment in the wound. So these things can lead to gas gangrene. So spore enter through devitalized tissue. So what happens here is that the spores enter through devitalized tissue. Usually it happens after RTAs and or crush injury. And here spores germinate inside the body. And they release bacteria will be released, and this bacteria will produce exotoxin. Here the toxins, what it does is that muscle glycogen is broken down into lactic acid, carbon dioxide, and hydrogen. So this is the reason behind the gas production. It is due to, we'll see what are the gases involved, but mainly hydrogen, carbon dioxide, and hydrogen sulfide will be seen in these gangrenes. And muscle glycogen, breaking of muscle glycogen leads to lactic acid, CO2, and hydrogen production. Then these organisms release protease, and they form amino acid, which further releases ammonia and hydrogen sulfide. So hydrogen sulfide is also produced. Excessive necrosis of muscle with production of these gases like hydrogen sulfide, nitrogen, and carbon dioxide. Usually muscle involved from origin to insertion. So we can see here in case of gas gangrene, entire muscle from origin till insertion will be affected. And it rapidly spreads, and it's often fatal disease. The common symptoms are all the features of toxemia like fever, tachycardia, hypotension. Then wound is under tension with foul smelling discharge. An important feature of gas gangrene is khaki brown colored skin that happens due to hemolysis. Due to these excess gases, crepitus is a feature of gas gangrene. So khaki brown colored lesion as well as crepitus. These two are the two important features that we should remember in case of gas gangrene. And organism also, please remember. So khaki brown colored lesion due to hemolysis and crepitus. Unlike other anaerobic infection, discharge in these infections is often non-purulent. Usually, anaerobic infections lead to purulent discharge. Here, it is not purulent. It is much thinner than normal pus, and that gives the characteristic dishwater pus. It's not thin. It's not thick. It's thin. So it gets a typical dishwater-like appearance. So it's called as dishwater pus. Wound is under tension with foul-smelling discharge. It has a decaying apple odor. The common sites of infection is frequent sites are adductor regions of the lower limb and buttocks and subscapular region in upper limb. It can also infect limbs, abdominal walls, appendix, gallbladder, common bile duct, intestine, and uterus. So there are a few types of gas gangrene. The first one is fulminant type. Second is massive type. Third is single muscle type, and the fourth one is group type. These are the important four types of gas gangrene. Fulminant type, rapid progression and often death. It results in death due to renal failure, liver failure, modes, and ARDS. So multiple organ distress and this fulminant type of gas gangrene can end up in multiple organ distress syndrome and even in acute respiratory distress syndrome. An infection of one group of muscle or extends one group of muscle like extensors of the thigh or flexors of the leg, that's called group type. So here one entire group of muscle will be affected. Then massive type involves one whole limb, and we can see full dark colored gas filled areas. Then the last one is single muscle type, where one single muscle is involved. And apart from these four types, one rare form is the subcutaneous type. It involves only subcutaneous tissue, usually caused by less virulent clostridial organism. But this fifth form is very rare. The common forms are fulminant type, group type, massive type, and single muscle type. The fulminant type is the most dangerous one, which can lead to death of the patient. Then diagnosis. Diagnosis X-ray usually shows gas in muscle plane or even under skin. Then CT scan of the part may be useful, especially in chest or abdominal wounds. Gram stains show positive gram-positive bacilli. Then Robertson's cooked meat media is used, which causes meat to turn pink with sour smell and acid reaction. That's all regarding gas gangrene. Next, we'll see about actinomycosis. Actinomycosis is a rare chronic suppurative granulomatous inflammatory bacterial disease close by Actinomycosis israeli. So actinomycosis, please remember this name because there is confusing names coming up. So actinomycosis is caused by Actinomyces israeli. It's a bacteria. So actinomycosis is a bacterial disease caused by Actinomyces israeli. It's an endogenous infection. It's commonly seen in tropical countries, and here we can see the bacteria. Their filamentous gram-positive organism, but due to the ray-like appearance, it is also called as ray fungus. But it's not a fungus; it's a bacteria. It's a gram-positive filamentous bacteria. So ray fungus causes actinomycosis. Ray fungus is Actinomyces israeli. It causes actinomycosis. The disease is characterized by the formation of painful abscess in mouth, lungs, breast, or GIT. So the most common location is face. So it's characterized by the formation of painful abscesses. And in actinomycosis, abscess grow larger as the disease progresses, often over months. In severe cases, they may penetrate the surrounding bone and muscle to the skin, where they break open and leak large amount of pus, which often contain characteristic granules filled with pyogeny bacteria. And these granules, there are some, it's called the sulfur granules. I hope you remember actinomycosis has sulfur granules. When we discussed about discharges, we have discussed about this. So actinomycosis is characterized by the presence of sulfur granules in the discharge. They are usually yellow in color, but this color can vary to white or gray or even brown. But sulfur granules is a characteristic feature of gas gangrene. So here the face is affected, and these nodules are painful. And the second image, I hope you can see in this tissue paper, this yellow color discharge. This is sulfur granule. So what happens here is that first bacteria which comes under the genus Actinomyces, especially Actinomyces israeli, enters into the body, and it enters especially when there is poor oral hygiene or any periodontal disease, radiation therapy, or people who undergo radiation therapy, or even due to trauma. This organism enter the body, and they cause a subacute inflammation with induration and nodule formation. So induration is a characteristic feature of actinomycosis, and eventually they lead to discharge sinus formation, and this discharge will contain sulfur granules. The pus will be having the typical sulfur granule appearance. So sulfur granules, what are they? They are gram-positive filamentous bacilli trapped in biofilm-like materials. Nothing but this bacilli, which is trapped in a biofilm-like material. And there are different types of actinomycosis according to the location. The forms are faciocervical, thoracic, right iliac fossa, liver, and pelvis. These are the usual locations where actinomycosis can happen. So if you look, we can see first clinical type is faciocervical. So it's a most common type initially, and in duration develop, and later, as we have discussed earlier, it will lead to this sinus, and sinus will eliminate discharge that will have sulfur granule. And the faciocervical forms of actinomycosis usually happen due to like poor oral hygiene, when there is a dental procedure, and due to similar reasons, actinomycosis of facial-cervical clinical type happens. Second one is thoracic form, and lungs, pleura, and chest will get infected in this form. Then there's right iliac fossa affection. Here, the usual presentation is mass in abdomen with a discharging sinus, and this discharge will also contain sulfur granule. The sulfur granule is especially seen in case of facial-cervical form. Then this disease can even affect liver through portal veins. And the last form is pelvic form, which usually enters through intrauterine devices. So these are the important 5 clinical types of actinomycosis: facial-cervical, thoracic, right iliac fossa, liver, and pelvic form. Then a clinical feature: discharging sinus with induration and nodules. Here it will be painful. First of all, it will be painful. Then there is discharging sinus, and as we have discussed earlier, it will that discharge will be typically sulfur granule type. And induration is one important feature. But even with induration, there won't be any lymph node involvement. Please remember, there won't be any lymph node involvement in case of actinomycosis. Then through blood, it can spread and it can result in pyemia, and in cases it can even endanger the life. Investigation, again, this branching filaments of pus with, under microscopy, it will show the branching filament of actinomycosis israeli. If it's actinomycosis israeli, it will show characteristic branching filament, and it will show that typical sundry kind of appearance. Then gram staining, gram positive. Here, one important thing is that this filaments will have gram positive mycelia in the center, with gram negative radiating peripheral filament. So the filaments here will be gram negative, whereas the center area or the mycelia will be gram positive. DDs are chronic pyogenic osteomyelitis, then TA of that particular site, or even tuberculous disease. The next disease that we're going to see is Madura foot. So it's a chronic granulomatous disease of skin and subcutaneous tissue. From this image, I hope you can see this disease is also called as mycetoma pedis. So Madura foot is also called as mycetoma pedis. If it affects the legs, it's called as mycetoma pedis. If it affects the hands, it's called as mycetoma hands. And so in general we can call it mycetoma. So it's a persistent fungal infection of the skin, commonly affects feet, but it can also affect hand and even other body parts. This disease is endemic to India, South America, Mexico, and sub-Saharan Africa. So please keep this thing in mind. Mycetoma can be produced by both bacteria and fungi. Fungus is the mainly it's caused by fungus, but even bacteria can contribute to mycetoma. If it's produced by bacteria, like the most common group of bacteria that produce mycetoma is Actinomyces group and Nocardia. I hope you remember actinomycosis, Israeli causes actinomycosis, right? So here Actinomyces group and Nocardia causes mycetoma. So Actinomyces group causes mycetoma also. And the most common fungi is Madurella mycetomi. And actinomycetoma, if mycetoma is caused by bacteria, especially if it's due to actinomycosis group, it's called as actinomycetoma. And if it's caused by fungi, it's called as mycotic mycetoma or eumycetoma. So mycetoma, mycotic indicates fungus. So mycotic mycetoma or eumycetoma. And if due to bacteria, it's called as actinomycetoma. So actinomycosis is totally different. This is actinomycetoma, which is a type of mycetoma produced by bacteria, especially Actinomyces group. So mycetoma due to bacteria. Actinomycosis is same actinomyces which produces a different disease. So please don't get confused between actinomycetoma and actinomycosis. So here mycetoma can be produced by both bacteria as well as fungi. Fungi, the most common fungi is Madurella mycetomi, and if it's due to fungi, it's called as eumycetoma or mycotic mycetoma. Whereas if it's due to bacteria, it's called as actinomycetoma. This is a picture of Madura foot. Signs and symptoms. Initial lesion is a small swelling under the skin following minor trauma. Painless wet nodule, which may be present for years before ulceration. Swelling and weeping from sinus followed by bone deformity. Sinus discharge a grainy liquid of fungal colonies. Usually it's black or white, 80% occur in feet. So here, this is important. Mycetoma symptom triad. There are main three symptoms that diagnoses it as mycetoma. First one is discharge with grains. Earlier we talked about different types of discharge, right? Here, mycetoma has discharge with grains. Grains can vary in color, but it can be yellow or black. But discharge with grains is one of the important feature of mycetoma. Then the second one is weeping sinus. I hope you remember from the picture, there were multiple nodules and each of it was weeping, like it had discharge from those sinus. And third one is painless firm skin lump. So this disease is completely painless. So these are the three important symptoms of mycetoma. It will discharge, it will have grainy discharge, then there is weeping sinus, and then there is painless firm skin lump. The discharging granule can be black, red, or even yellow. So in black type of Madura foot, infection is mainly subcutaneous. If this Madura foot is of a subcutaneous nature, then usually the discharge will be black type. Whereas if it's red or yellow in color, it's more dangerous because this variety, it burrows deep into deeper planes, and even the bone can be included. So bone necrosis or osteomyelitis is a complication of Madura feet. So eventually, gross swelling of the lymph with multiple discharging sinus with disability will occur, and even muscles and bone can be involved. Regional lymph nodes are not involved in Madura feet also. So in the second picture, I hope you can see multiple nodules are there, and each of them are having sinus, and they. I hope you can see discharge here, but it's usually grainy in nature. And this disease is acquired through entry of fungal spores from the soil through breach of skin. It can happen through fungal origin as well as bacterial origin. So the most common cause is breach in the skin. So it's spread to deeper tissues from and form sinus tract leading to skin surface. Mature lesions are characterized by grainy discharge containing fungal colonies. Spread internally through blood or lymph is uncommon. So usually the spread is local in nature. Lymphatic or hematological spread is not very common. Here, organism enter through a prick in the foot. Usually, when the patient walk barefoot, and once the organism reaches, it invades into the deeper planes of the foot. And then, after invading into the deeper planes of the foot, it evokes chronic granulomatous inflammation, and that causes painless firm nodules. Formation of vesicles, and eventually it will form vesicles, and this vesicles will burst and they'll start sinus. So here we have to understand that this organism travel into the deeper planes, and in the deeper planes they cause granulomatous inflammation, and from there sinus tract will be forming, and this sinus tract will went out through the skin into the outside of the body. So here the infection is very deep in nature. And diagnosis is usually done by biopsy, visualizing the fungi under microscope and culture. Then medical imaging may reveal the extent of bone involvement. Then ELISA and immunodiffusion and DNA barcoding can be done to identify the organism. So here, in order to prevent Madura foot, wear protective footwear in endemic region. Then avoid direct contact with soil or water. And the next disease that we're going to see today is nosocomial and opportunistic infection. We know about nosocomial and opportunistic infection. So if you see nosocomial infection, nosocomial means they're hospital acquired infection. So infection acquired in a hospital or from any healthcare facility is called as nosocomial infection. They spread by various means. They can spread from one patient to another. They can even spread from healthcare staff to patient, or through contaminated equipments, bed linens, air droplet, like that. So the source of nosocomial infection, usually how it enters the body. So it can enter in multiple ways. through contaminated infected wound it can enter, then through UTA, in the form of UTA it can enter the body, then as respiratory tract infection it can reach the body, it can even reach as opportunistic infection, which we'll see later, then even through abdominal or any other wounds, this nosocomial infections can enter the body. So nosocomial infections are simply infections that we get through this health setting. The most common organism that is responsible for hospital acquired wound infection is Staphylococcus aureus. And there are other organisms also like Pseudomonas, Klebsiella, E. coli, Proteus, Streptococcus pneumoniae, Haemophilus, Herpes, Varicella, Aspergillus, Pneumocystis cardini. So all these organisms can cause nosocomial infection, but the most important organism is Staphylococcus aureus. One more important thing to remember in case of a MCQ is hospital acquired UTIs are mostly due to Klebsiella, not due to Streptococcus aureus. Hospital acquired UTIs are mostly caused by Klebsiella. This is one important question. Klebsiella is the most common pathogen involved in hospital acquired UTI. So it's commonly seen in individuals with diabetes, then immunosuppressed individuals, then patients on steroid therapy and other life supporting machines, then instrumentations like patients who has a catheter or IV cannula or tracheostomy tube. These patients can also get nosocomial infections. So these are here the important thing is to remember the organism. Staphylococcus aureus is the most important organism. And one more point is Klebsiella that causes hospital acquired UTI. These two are the important points when it comes to nosocomial infection. To prevent, there should be strict practice of strict sepsis. And there is opportunistic infection. So we know opportunistic infection, like it when the patient's immunity is weakened, and due to that reason, if we get infection, that's called as opportunistic infection. That can stem from a weakened immune system, altered microbiome, or breached in integumentary barriers. So opportunistic infections are caused by pathogens such as bacteria, fungi, parasites, or even viruses. Here we know these are the important causes of immunodeficiency. So people who are diabetic in nature, then HIV patients, then patients under steroid therapy, patients who undergo radiotherapy, then patients who take radiosuppressive therapy in transplantation, then cytotoxic chemotherapy, then starvation in old age. All these things can lead to immunodeficiency, and that can I mean expose the patient to a whole set of disease, and they can catch these opportunistic infections. Here, the most common organism is again Streptococcus aureus, Staphylococcus aureus, and the bacteria, both gram-positive and negative organism is responsible. Then virus, fungus, and even protozoa can cause to opportunistic infection. Here, in case of opportunistic infection, immunodeficiency is the cause. Now, the next disease that we're going to see is anthrax. Anthrax is an infection caused by bacterium Bacillus anthracis, and that's a gram-positive, aerobic, spore-forming, capsulated, non-motile, non-AFB, and is resistant to heat and antiseptics. So the organism behind anthrax is Bacillus anthracis. This is common in cattles, and so it's seen in people who can handle carcasses, wools, and hairs. Occupational exposure to infected animals or their products is the usual pathway of exposure. So we know these are the four forms of infection. Here, the disease which anthrax that affects the skin is the very common form. Then it can also affect lungs. It can also affect the intestine. But there is another very rare chance that people who take drugs and all, people who share their like needles, they can also get anthrax. It's a very rare form called as injection anthrax. So mainly there are 4 types of anthrax. We'll see one by one. First is the cutaneous type. We know that cutaneous type is also called as Hyde-Potter's disease. It's the most common type with symptom onset occurring between 1 day and more than 2 months after infection. So the incubation period can vary from 1 day to more than 2 months. It's characterized by indurated papule with black slough surrounded by vesicle. We know it's also called as malignant pustule. Then regional lymph nodes are involved. So the first form is cutaneous form. It's the most common form. It's also called as hypotus disease. So people who work in leather factories or it's such people usually get this disease when the skin is directly exposed to the pathogen. Then the second one is respiratory type. Here, the spore has to enter the respiratory tract. So wool sorters usually get this disease commonly. So it's called as wool sorters disease. It occurs by inhalation of spores causing hemorrhagic pneumonia. Hemorrhagic pneumonia is a feature of anthrax. It's a feature of respiratory anthrax. So that you please remember, hemorrhagic pneumonia is a feature of respiratory anthrax. More dangerous and it's more dangerous and life threatening. Here, 50% of respiratory types complicates and become meningitis. And the third type is elementary type. So GIT anthrax can occur. How it occurs when spores are ingested, and how does someone ingest a spore when the meat is undercooked? If the cow the meat is undercooked, it can lead to elementary forms of anthrax. So fatal septicemia and meningitis can occur here also. Here, these are the symptoms of elementary type of anthrax. Common symptoms like nausea, vomiting, abdominal pain, then headache, loss of appetite, fever, severe bloody diarrhea in the later stage of the disease. It's also accompanied by sore throat, difficulty in swallowing, and even swollen neck. So these are the symptoms of intestinal or elementary type of anthrax. The last form, which is very rare form, and that's called as injection anthrax. Anthrax that occur at the site of injection. Here, the injection form presents with fever and abscess at the site of drug injection. So usually when drug addicts they exchange their needle, this anthrax can happen. Especially if one person is having cutaneous variety of anthrax. Diagnosis is usually done, culture of the fluid that will show medusa head appearance. So medusa head appearance is a characteristic feature of anthrax. Please remember, medusa head appearance is a diagnostic feature of anthrax. This is how this film will typically look like. So what is Medusa? Medusa is a Greek goddess who had like curly hair, wavy hair. So here, if you look at the image, you can see typical filament, right? So this filaments will the bacillus filaments will get will club together and they'll form this characteristic curly hair like appearance, and that's what is called as medusa head. So medusa head appearance is a characteristic feature of anthrax. Please remember, medusa head anthrax. Ne- Next disease that we're going to discuss today is necrotizing fasciitis. It's also known as flesh-eating disease. Necrotizing fasciitis, often known as flesh-eating disease, is a bacterial disease which results in death of soft tissues in the body. It's a serious illness with an abrupt onset and a rapid spread. Symptoms usually include a red skin in the affected area, severe pain, fever, and vomiting. Most commonly affected areas are limb and perineum. So here, if you see this picture shows necrotizing fasciitis. It's a spreading inflammation of the skin, deep fascia, soft tissues with extensive destruction. Common in old age. Here, one important thing is that in case of necrotizing fasciitis, this necrosis is limited up to the level of fascia. It will not go beyond the level of fascia. So usually muscles and even muscles are spared. So we won't be seeing much bone involvement or anything like that. So usually necrotizing fasciitis, here the necrosis is limited till the levels of deep fascia. So deep fascia, soft tissues, skin, everything will be destructed, but muscles will be preserved. This disease is common in old age, smokers, then people with diabetes, then immunosuppressed individuals, malnourished people, people who are obese, then people who undergo steroid therapy, and even HIV patients. And common symptoms are fever, swelling, pain, skin changes, hardening, bleeding, and reduced sensation. The most common organism responsible for necrotizing fasciitis is Streptococcus pyogenes. Mixed infections like anaerobes, coliforms, gram-negative organism can also happen. When we see the subtypes, you'll understand more. Risk factors are more than 70% of the cases are recorded in people with at least one of these clinical situations. So people with immunosuppression, then diabetes, alcoholism, drug abuse, smoking, malignancy, chronic systemic disease, people who already have these disease, there is a chance of getting necrotizing fasciitis. So necrotizing fasciitis, 70% of the cases are seen in people with these clinical situations. And but for reasons that are unclear, it is also seen in people with apparently normal general condition. So it can affect people without any apparent illness also. So there are a few subtypes for necrotizing fasciitis on the basis of the organism affecting. So first one is polymicrobial, and that's type 1 necrotizing fasciitis. Type 1 necrotizing fasciitis is the most common form, and that's due to a polymicrobial, that's having a polymicrobial etiology. Up to 70 to 80% of necrotizing fasciitis occur due to multiple bacteria, a mixture of bacterial types. Here, the bacteria are Staphylococcus aureus, Streptococcus pyogenes, Enterococci, Escherichia coli, then Pseudomonas, bacterioids, Clostridium species. All these multiple bacteria can lead to type 1, which is the most common form. So, necrotizing fasciitis up to 70 to 80% is contributed by multiple bacteria. And here the most common location is abdomen and groin. In this image, I hope you can see how the entire abdominal area and groin area is affected. It usually affects older people with medical comorbidities. The second form is monomicrobial. Here, usually one single organism will be responsible. This type infection accounts for about 20 to 30% of the cases. Here, extremities are usually involved. And as we discussed earlier, the most common pathogen behind this is Streptococcus pyogenes. This alone, usually Streptococcus pyogenes alone is the reason for type 2. But in some conditions, Staphylococcus can also contribute. So in case of monomicrobial, it is mostly it's due to Streptococcus pyogenes, but at times this monomicrobial can also contributed by staphylococcal species. So both types of bacteria can progress rapidly and manifest as toxic shock syndrome. When we learned about toxic shock syndrome, the most common organisms were these two. So Streptococcus pyogenes, when it affects when it leads to necrotizing fasciitis, it can lead to TSS, and it's commonly seen in younger individual. Whereas type 1 was most common in older people with some immunodeficiencies. Then we have type 3. Type 3 is particularly caused by Vibrio vulficus. So this bacterium is usually seen in salt water. So this image in the image below shows how this necrotizing fasciitis of Vibrio vulficus is different from other forms. So initially this will progress similar to type 2, but later we can see visible skin changes. It's having a slightly yellowish color, whereas the second form was having this blackish, purplish black color. Even the first form was almost similar, whereas the third form, type 3, is having visible skin changes. Usually, this Vibrio vulficus is a saltwater bacterium. It's found in saltwater. Last form, it's due to fungus. So type 4 is due to fungus, and that's Aspergillus zygomycetes. It's a very rare form. Type 4 is due to fungus. So necrotizing fasciitis, there are 4 types. First one was due to polymicrobial etiology. It's the most commonly seen variety, and it's seen in people of old age. We can see a mixture of bacteria responsible for this. Second one was monomicrobial, which account up to 20 to 30%. Here, the most common organism is Streptococcus pyogenes, but at times Staphylococcus can also cause this. It's seen in younger individual. Type 3 was due to Vibrio vulficus, and again, this is a bacterial disease. This bacterium is seen in salt water. Here, the skin changes somewhat yellowish in color. Then type 4 is due to fungus, and this is the rarest form. This is about necrotizing fasciitis. Here, one important thing to remember is that muscles are not usually involved in necrotizing fasciitis because it's limiting up to the level of deep fascia. Here, Necrotizing changes affecting the groin has a special name that's known as Fournier's gangrene. So Fournier gangrene is a gangrene where the necrotizing changes are usually confined to groin area. This is a image of Fournier gangrene. And in addition to this, the clinical features are sudden swelling and pain in the part with edema, discoloration, necrotic changes, ulceration. Then there will be foul smelling discharge. Then other features of toxemia like high grade fever, chill, hypotension can be seen. Then oliguria with acute renal failure due to acute tubular necrosis. Then jaundice, then rapid spread can be seen within hours. This disease can spread. Here, diagnosis gold standard for diagnosis is surgical exploitation. By looking at the lesion, it's not always easy to diagnose the disease. So, in order to diagnose, what is done is a small incision can be made into the affected region. Then a finger easily separates the tissues along the facial plane. We know this disease limits at the level of fascia. So when a finger is passed, it easily separates the tissues along the facial plane, and that's how diagnosis is done. And once diagnosis is done in this way, excessive debridement should be performed for the regeneration or tissue. In order to prevent, the best way is to clean the wound, practice good hygiene, and seek medical attention if any of the signs are there. The next disease is acute pyomyositis. So pyomyositis is an infection and suppuration with destruction of skeletal muscle, commonly due to Staphylococcus aureus. So 90% of pyomyositis or acute pyomyositis is due to the presence of Staphylococcus aureus. In addition to that, Streptococcus pyogenes can also contribute to the disease. And very rarely, gram-negative organism can also produce the disease. Bacterial infection with destruction of the skeletal muscle result in an abscess formation. In this image, I hope you can see the abscess that has formed. Commonly caused by Staphylococcus aureus and Streptococcus pyogenes. Okay. So epidemiology, if we look, it's a disease which is mainly seen in children of age 2 to 5 years. Even though it can affect people of any age, it's usually seen in kids between the age 2 to 5 years. Infection follows minor trauma and is most common in tropics, where it accounts for 4% of all hospital admission. In tropics, it accounts for 4% of all hospital admission. It's seen in children, and it is usually seen in the form of an abscess. Infection can affect any skeletal muscle, but most often it affects large muscle groups such as quadriceps or gluteal muscles. Organism we discussed earlier, it's due to most common causes Staphylococcus aureus. But in addition to this, it can also cause by gonococcal, gonococcae. Neisseria gonorrhea can also cause acute pyomyositis. But the most common organism is Staphylococcus aureus. Here, this is an image of acute pyomyositis. It commonly affects the muscles of thigh, gluteal region, shoulder, and arm. Repetitive factors are similar to necrotizing fasciitis like trauma, malnourished children, anemia in children, then immunosuppression in children. It leads to acute pyomyositis. So it's usually a disease of children, whereas necrotizing fasciitis was mostly seen in older individuals and adults. But in children, acute pyomyositis is commonly the disease that age group is affected. Here, pain, edema, tenderness with induration, and muscle spasm are the common symptom, along with the lesion. Then fever, jaundice, uremia can also be seen. And these are the precipitating factors: trauma, malnutrition, anemia, and immunosuppression. Diagnosis here, CPK will be raised in the acute phases. MRI can confirm the diagnosis. The age group and the organism has to be remembered. That's all regarding today's